Hello, everyone, and thank you for taking the time to join our webinar today to provide an update on the novel OPV2 and nOPV2 rollout. My name is Simona, and I work with the WHO Polio team based out of Geneva. And together with Ananda, I also co-chair the nOPV2 working group of GPEI. And it's great to see so many of you on the call today for us to be able to provide you with an update on how things are going with the rollout and answer any questions that you have. It is an area where a lot of things are changing quickly, so it's hard to always have the latest information at your fingertips. And we wanted to make sure that all of us as a GPEI family were up to date and had a chance to discuss where things are at and where they're going with the nOPV2 rollout. Next slide. We have a busy agenda for you today, so I won't spend long on the introduction. We have 7 different presenters from across the GPEI partnership, as well as from the regional level, who will be giving updates on the various parts of the nOPV2 work. We're going to go through all of the presentations, none of them are too long, and then we'll open the floor up for questions. Next slide. Before we get started, I wanted to just go over a few little bits of information regarding how we're going to run this meeting. We're all experts on Zoom by this point in the pandemic, but we all also run our Zoom meetings a little differently. So wanted to make sure that you were aware of how things will work today. So the first thing we wanted to highlight is that we do really encourage you to join using the Zoom link in your Outlook invite so that you're joining via the Zoom app on your phone or via Zoom on your computer. If you're dialing in from your phone, the Q&A function will not be available. As well, you may not be able to access all of the various features in the Q&A section. So if you are able to join via a computer, that is the best bet. The other thing we would like you to do, if possible, is for you to make sure that your name, your display name, is your actual name and not iPhone or not your child's name from their Zoom meeting, and your organization, so that everyone knows who is who when you ask a question. And instructions for how to do that are on this slide here. So you can do that by clicking on the 3 dots that are in the upper right-hand corner of your video and then selecting rename. You can see that highlighted in yellow on the right-hand side of your screen. Finally, during today's session, you'll notice that there isn't a chat function available. That's so that you are not busy saying hi to everyone you may not have seen in a while, but instead are able to focus on the presentations, but also for us to make sure that we're able to get any questions that you ask in an organized fashion. We're going to be using the Q&A feature rather than the chat. And so you'll see that Q&A button on the bottom of your screen. And at any point during the session that you think of a question, please feel free to type it in that Q&A box. And if there's a question you want to ask that you prefer to do anonymously, you do have the option to do that as well. We'll be collecting all of the questions as they come in, and we will be trying to get through as many of them as possible during the Q&A session. Our panelists will also try to reply to some of the more simple questions via chat during the meeting using that Q&A feature as well. So please do feel free to ask your questions. I know there's a lot of presentations, but we also want to make sure there's enough time for discussion. And we want to make sure your questions are answered. And anything we don't have time to cover during our live Q&A today, we'll take note of and make sure to follow up on by email. So please do make sure to send in your comments and questions. There is no such thing as a stupid question. There isn't something you should know at this point. Everything that you're wondering is a valid thing to ask. So please do feel free to do that. Finally, just to let you know that if you do have any technical issues during the meeting, you can enter those in the Q&A box. We have technical support on the line who will be able to assist you. And if you're having problems with Zoom itself or you get disconnected, you can email Megan. Her email is here, and her phone number is there as well if you have not been able to join via email, or you're kicked out of the Zoom application and you're not able to join again online. Finally, just to let you know that we will be recording this webinar. The webinar will be recorded in English, so that it can be shared with colleagues who weren't able to join today. So please note it will be recorded. With that in mind, I'm going to hand it over to our first presenter, who needs no introduction to most of us, although he is new, so perhaps he does for some of us. Aidan O'Leary is the new director of Polio for WHO and also the chair of GPEI's Strategy Committee, which is the group that directs GPEI's strategic activities and also oversees the operational functioning of the program. So for those of you who haven't met Aidan, this is a great chance to at least see him and get a sense of who he is. So Aidan, we'll pass the floor to you and hope your internet connection in Brazzaville holds out.
So thanks very much, Simona, and good morning, good afternoon, and good evening to all who are participating. Greetings from Brazzaville, and I think it's very heartening to see such a high level of representation from across the partnership at all levels, global, regional, and country. And I hope you find the webinar today both are useful and instructive. And again, to echo the points that Simona highlighted around, if there are questions, please let's use the opportunity of this webinar to try and make sure that they're addressed. I would offer just one clarification to Simona's introduction. So she described me as the director of Polio. The DG in all his engagements goes out of his way to describe me as the director of Polio Eradication. And again, I think it's a small little thing, but again, just to re-emphasize that it's all about getting to and sustaining zero. So just to add to that. I think that it's a particularly important and timely webinar. We're basically doing it against the backdrop of a rising CVDPV risk. And this obviously occurs where a weakened strain of poliovirus circulates amongst underimmunized populations for very lengthy periods of time and genetically reverts to cause paralysis. And what we've seen since 2016 is almost 1,600 cases of circulating vaccine-derived poliovirus, and obviously real concerns about the spikes that emerged in 2018, 2019, and then again between 2019 and 2020, where in each year there was threefold increases in the volume of cases being reported. So clearly, something had to change. And I think we're very, very fortunate that through a lot of hard work and a lot of effort, we received the emergency use listing for the novel nOPV2 vaccine back in November of 2020. I think the initial use phase clearly is very demanding across a broad range of requirements for countries. And I'm hugely thankful and hugely impressed by the enormous volume of work being conducted by countries across the partnership themselves to try and make sure that as many countries as possible meet those criteria as quickly as is feasible. We have almost 30 countries, the vast majority based in the Afro region, which has taken a very strong leadership role in the rollout of our vaccine. And what we are beginning to see is a steady and building momentum towards readiness and verification, and more importantly, to see our introduction and delivery of this vaccine at scale. To date, we've seen Nigeria, Liberia, and Benin most recently, with a number of other countries are either imminent or on the verge of conducting supplementary immunization activities. And again, I think it's particularly important that our momentum is sustained, and also the follow-up work that is also underway to make sure that we do move from this initial use to the wider use phase. And again, I would like to extend a particular thanks and word of gratitude to the Nigeria and Liberia teams and all GPEI partners who've been involved in the follow-up of both safety and surveillance data to try and make sure that the work of the Vaccine Safety Committee is as fully informed as is feasible. The next meeting of that particular committee is on the 26th of May. And what we are really working towards is to try and ensure that we move from this initial use to wider use phase during the course of Q3 of this year. And again, step by step, we are building momentum, and we hope to be able to sustain that momentum through Q3 until the end of the year. I would highlight that, notwithstanding this move to our wider use, we will remain under our emergency use listing requirements until the last quarter of 2023. So the recent sage advice around making sure that all countries take as many preparedness steps as is feasible, as early as is feasible, I think is particularly important and relevant. There is clearly a path to move forward in terms of the next stage, but it's also important that we continue to maintain the flexibility to respond to outbreaks and detections once notified. So in that regard, the importance of using the available vaccines, whether nOPV2 or TOPV, continues to remain very pertinent in this regard. So clearly the nOPV2 vaccine is potentially a game changer for the program, and we very much hope that it is going to, as our SAGE described it, become the vaccine of choice when it comes to CVDPV outbreak response. So where does this fit into the overall recent revamp of strategies? We have reiterated the goal of interrupting and our certification of our wild poliovirus 1, and also the interruption of CVDPVs during the course of the 2022-2026 strategy. Vaccines on their own simply won't do it, but they give us a really, really important tool inside our toolbox to make sure that we are as effective and efficient as we possibly can. We will be working to strengthen other elements of our outbreak response, starting with the timeliness and the sensitivity of our surveillance systems, the timeliness and quality of our outbreak response, working to strengthen routine immunization, particularly in those areas where we have our zero-dose communities, noting that more than 90% of the CVDPV or cases that have been recorded to date have been zero-dose for IPV. So we must be working not just on cure, but also working on prevention as well. As we roll forward through Q3 into Q4, we also hope to build on what I would call sub-regional components to response, recognizing that viruses don't recognize any borders. And what we really want to make sure is that we go after this or these outbreaks in as aggressive a way as we possibly can, with a view to contain and then close them off as quickly as is feasible. And then last but not least is to emphasize the importance of engagement at all levels. And again, to highlight, particularly with the recent IHR Emergency Committee, a very strong onus towards the declaration of national health emergencies. And again, the whole idea behind this is both for governments as well as the GPEI at all levels to make sure that we do shift our game to really bring around a tangible timeline and our trajectory towards zero CVDPV over the coming years. On that note, thank you very much again for your participation. Back to you, Simona.
Great, thank you so much. As Aidan highlighted, we have seen a huge amount of progress towards nOPV2 use in the African region. We do also have the European region with Tajikistan planning an nOPV2 response at the end of this month. And we have 5 countries in the Middle East that have also started preparing for nOPV2 with the goal of using the vaccine towards the end of this quarter or early next quarter. So we are seeing progress in several regions, but indeed it is the African region that has been leading in terms of accelerating the pace on the rollout and getting the vaccine in use. And so we're really honored today to have Dr. Richelot with us, who is the nOPV2 lead for the African Rapid Response Team, which is a partnership-wide effort to support outbreak response in the region. And Dr. Richelot took on the nOPV2 job, probably not realizing quite how much work it would be, but we're grateful for his leadership and stewardship every day. And so I'm very honored to have him here to give us an update. So Dr. Richelot, over to you.
Good afternoon, Simona, and good afternoon, all colleagues. My name is Richelot Ayama. I'm working for WHO based in Brazzaville, the regional office, and I'm the member of RT, the Rapid Response Team, and focal point of nOPV2. So for the next couple of minutes, I'll take you through a few slides, and starting by the CVD-PV2 epidemiology in our region. As you can see on this map, for the period from January 2020 to May 21, we observe on the map that we have CVD-PV both type 2 coming from the environment and from the AFP cases with a predominance for type 2. And we can see also that a response has been started in 2018, and we can see that now there's no CVD-PV2 reported from Ghana, Togo, and Angola for the last 6 months. So on the note, we have more than 500 CVD-PV2 from AFP and more than 177 now from ES. Next, so to be prepared for nOPV2 rollout, a coordination structure has been set up within the RRT. RRT, as Simona said, is a multi-agency structure based here in Brazzaville. Next slide, please. And the first thing was really to build a regional support to assist the countries. And when we see this structure at the regional level, there is a kind of a working group that I'm a focal point with the project officer and country support. We can see the main responsibility of the project officer and the country support at the bottom of the slide. But I really want to emphasize on that small group, that technical group coming from several agencies and having expertise in different areas. And those technical expertise are very helpful and important to support the country. So we have domain like regulation, surveillance, vaccine, safety surveillance, and C4D. Next. So after the regional level, we came to the country level to make sure that we have the coordination mechanism. So I want just to give that example of the country where we have a GPEI coordinator. Within the structure, within the team, we assign one focal point, a national focal point, really working to make sure that, first of all, we have all the materials, all the documents are submitted. So the national focal point is responsible of the coordinations, the rollout at the country level. But next slide, but based on the country are sometimes very different. So we have also the country based on the challenge where we can have a national facilitator. That national facilitator who is reporting directly to the WR is really in charge of the advocacy. Next slide, please. All right, so what are now the key activities that were implemented? If we really want to make a summarize, we think that the first point is the capacity building at the regional level with really the support of the global level. I think that was the first phase. And then the second phase was also to reinforce the capacity building at the country level. Those are really the main activities. And as you can see at the bottom of the slide, in addition to those activities, when we start working with countries, we were able to see that there were still countries who are having some challenge really to get the approbations. And then we asked two senior consultants who are well known in Africa to really come and support us so that we can continue to support the country. So next slide, where we have having done all those activities, having implemented those activities. Next, please. So when we see this graph shows the progress made by the country. As you know, the situation is dynamic and change every day, but at least it provides information on current trends. So we have a total of 5 countries, that was already said by Eden and Simona, and we have really countries that are very close, like Congo, Chad, and Uganda, and we will continue. At least our challenge is to have more green on this graph, and we will continue. But when we see on the bottom of this graph, we can see country like Gambia, which have started also to submit documents. And since yesterday, we have countries like Guinea-Bissau, Mauritania. They are not on this graph, but just to show that the situation is dynamic and we are recruiting more and more countries. Next. Just to mention that there are countries like Nigeria and Liberia, Benin, who have already started to implement SIA using the vaccine, and it's more than 10 million of children vaccinated. Next slide. And we continue to see how we can plan. If we see for May, we have Sierra Leone, Liberia, Congo, Benin for round 2. Niger, also early June, the date is not settled. We have also, we anticipate for Chad also. And when we see the estimate populations for those planned SIA, it's more than 9 million. That means now we hope that by June, we will vaccinate at least 20 million in our region. Next slide. So by implementing, we have a challenge, in everywhere, any time we implement activities, program, we have challenge. The main challenge are presented in this slide, but really I want to specifically mention the COVID context. Maybe the other presentation will go in details on that, but I want to flag that the COVID context was a kind of challenging. The other challenge is related to coordination mechanism, but I can guarantee you that through the discussions, interactions, we are really working to have all those challenges been taken into account in our activity. Next slide, I think it's the last slide. All right, the next slide is the way forward. We really want to continue to support nOPV2 initial use, meet all the requirements. This is really what we really want. We continue to update the priority countries because the support we are providing is based on our list case priority. The third point is really to make sure that all those documents that are coming from the country at the given times, we can quickly look at them and really provide the support. It takes now like 2 months, but if you can reduce to 1 month, I think that will be good. The last point is not really settled, it's really on the discussions. I put that map here, but it's just in perspective. In case it's agreed that we have a synchronized campaign in Q3, the group really wants to make sure that all the countries that are planned for this SIA will meet all the requirements. So, Simona, this is what I wanted to share with colleagues, and thank you for the opportunity of giving me the floor. Thank you.
Thank you so much, Dr. Richelieu. I think this really highlights the amount of work that is needed to support countries to prepare to meet the EUL requirements. Indeed, as we talked about on the last webinar, because nOPV2 is being used under an emergency use listing, there are requirements around its use, and it takes a while to meet those requirements, and that timeline of 2 months is noted. And going back to Aidan's point earlier about not delaying outbreak response, it really does highlight that for countries that want to use nOPV2, it is really important to prepare before they have an active outbreak or the need to respond. So I think that's a very important lesson for us to learn, and you've given us a sense of what it takes to support countries to get to that point. One of the things that you highlighted was around the time that it will take to meet some of the specific requirements for surveillance, for example, having functional environmental surveillance. And that is one of the requirements that exists only during the initial use phase, the phase that we're currently in now. And so we're very happy to have Grace with us today. Grace is the technical coordinator for the nOPV2 working group amongst her other day jobs. And she will be talking about the process and the timeline for the move out of the initial use and into the wider use, and what that will mean for the program and for countries looking to use the vaccine. So Grace, over to you.
Hi everybody, this is Grace Macklin here. I am a technical officer at WHO Polio in Geneva. And as Simona said, I'm supporting the nOPV2 working group, and particularly looking at policy of nOPV2 rollout. So I'll be discussing the initial to wider use of nOPV2. So on this slide here, you can see the timeline or phases of nOPV2 rollout. So phase A was prior to any EUL approval, and phase B is what we are currently in the initial use of nOPV2 under EUL. And in this phase, countries that can meet the initial use criteria and post-deployment monitoring requirements can use nOPV2. So the recommendation of nOPV2 under EUL comes with mandatory post-deployment monitoring that the GPEI have committed to and countries must meet. And that is valid for the entire process of nOPV2 use under EUL. However, as the GPEI, we additionally added in an initial use phase to govern the very first few uses of nOPV2 out of clinical trials and in the field. And we developed some initial use criteria that we made mandatory for countries to meet to be able to use nOPV2 in this period. And that was essentially to ensure we had the capacity to monitor and evaluate vaccine safety in the field and respond to any unanticipated events. So after the initial use phase, we process into phase C, which is wider use of nOPV2 under EUL. And in this phase, nOPV2 would become the vaccine of choice for responding to VVPV2 outbreaks. And countries must still meet and commit to the post-deployment monitoring requirements, but they no longer need to meet the initial use criteria, these additional safety evaluation criteria that we have imposed. And then phase C would continue until the eventual licensure and pre-qualification of nOPV2, when all countries would respond then with nOPV2. So next slide, please, Emily. So what will change as we transition out of this initial use phase and into the wider use of nOPV2 under EUL? So the initial use criteria here shown on the right-hand side will no longer be mandatory. And therefore, more countries will be able to use nOPV2 instead of MOPV2. And specifically, that's those without environmental surveillance, those with weaker AFP systems as no minimum threshold must be met, and those that have recently used MOPV2. So in the initial use criteria, you can see those criteria highlighted in red, which will no longer be mandatory or evaluated for countries to use the vaccine. So one of those is environmental surveillance and also a time period of 12 weeks from MOPV2 use in the area. So that was mandatory in the initial use period. So we could identify any adverse events or genetic sequencing and attribute it to either MOPV2 or nOPV2, and also evaluate the effectiveness of nOPV2 in stopping outbreaks. So these criteria will no longer be mandatory, but countries must still conduct post-deployment surveillance. So next slide, please, Emily. So this transition or the lifting of the initial use criteria, what are the policy steps in place to evaluate and make this decision? So we have a GAC-VS subcommittee on the safety of nOPV2, and they're an independent board that has been established and reports to the full GAC-VS, and they are reviewing safety data collected after every campaign with nOPV2 in this current initial use phase. And this independent subcommittee will make a recommendation to the GPEI, to the nOPV2 working group, once they have concluded that the safety data from the initial uses is sufficient to support the move to wider use, where we acknowledge that the surveillance will not be as enhanced as it has been in the initial use. And when they make this recommendation, then the GPEI, through WHO Polio, will present this to the SAGE, the Strategic Advisory Group of Experts on Vaccination, for review and their endorsement to endorse this transition from initial to wider use. So the safety data, AEFI and AESI, which are adverse events of special interest, will be the main consideration in this decision. And the genetic stability data of isolates of nOPV2 collected from the initial use countries through environmental surveillance and also AFP surveillance will support the decision. Next slide, please, Emily. So when do we expect this to happen? So we cannot say exactly when there will be enough data to support the move, as this is being decided by an independent board that have both expertise in polio and also vaccine safety. But what we expect is that the initial use criteria will be in place until at least July 2021. So the first use started on the week of March 15th in Nigeria. So July 23rd would be the first opportunity for SAGE to endorse the end of initial use, as by that point there will be round 1 and round 2 safety data collected from 6-week follow-up period after each round, and then a further 1 month for in-depth country assessment and causality assessment of any safety flags. So the July 23rd would be the first opportunity if the data from Nigeria of 2 rounds of approximately 7 to 8 million doses is sufficient. But shortly after, we will also have additional information from second country, Liberia, to add to this safety database to see when the independent board feel there's significant use of vaccine with high quality surveillance and the absence of any red safety flags to move to wider use under EUL. That is everything. So thank you very much, and happy to answer any questions in the chat or at the end of the session, as Simona said.
Great, thank you so much, Grace. It's indeed been a very thorough piece of work that you've done around outlining the policies and mapping out the different steps. And I think it is really important to note that July 23rd is the earliest possible time, but it is a reality that may be delayed if additional information is required or there's any delays in submission of data. And so as Dr. Richelot highlighted, this is why the timely submission of the safety data is so critical. We will have a more in-depth discussion on safety a little bit later. So please do keep putting your questions in the chat as you think of them, and we will get to them today, or if not, afterwards. With that in mind, I'm going to pass over to Mariana. Mariana is another woman who wears many hats, but today she is coming to us as one of the co-leads of the GPEI nOPV2 communications project team, which is part of GPEI's global communications group. So Mariana, over to you to let us know how things have gone on the communication side. And this has been a really important area for us to make sure there is high acceptance of this vaccine, especially given that it's being rolled out under an emergency use listing, which is a new concept for many countries. So Mariana, over to you.
Thank you, Simona. Good afternoon, everyone. My name is Mariana, and I am a C4D specialist with an outbreak team, UNICEF, based in Geneva. I'll give an overview of what it means for a country to get ready and prepared for the introduction and use of nOPV. And as Dr. Richelot was highlighting, there are certain criteria and documents that countries need to prepare for communications. There are 3 documents under G category, and it's an advocacy strategy, a behavior communication strategy, an action plan, and a crisis communication plan. Communication also has a big role in preparation of vaccine-related event plan, and it's directly linked to the crisis communication plan. Next slide, please. The support that we've provided so far from HQ level and RRT was to actually work and coach the countries in preparation of these documents, as a lot of them are new and a lot of them are have new guidance that is tailored specifically for nOPV and specifically for nOPV rollout under the emergency use listing. So across the teams, we've been working with countries to help them prepare these 4 documents and get them verified. Verification, I believe, was also mentioned, but the verification process took place from a regional level and then at the global level. So we've all been involved in seeing all the great plans that countries are putting in place. We have also deployed comms specialists and C4D support to the countries to support the implementation and to jumpstart the process of preparation of these documents. We have also put a lot of effort and continue putting a lot of effort into the misinformation management work. I'll talk a bit about the misinformation later in the presentation, but there are a lot of resources already available and were deployed. Specifically on C4D side, we've provided, and it's available, the standard package and the key messages for polio response and that are tailored for nOPV. Monitoring and evaluation frameworks and guidance are also there. Post-campaign monitoring is also available and been used by the countries. On the HR side, there is a comprehensive global roster that countries were and are encouraged to tap in to get support quickly and get communication professionals on the ground quickly to either prepare the documentation or implement the campaign. We have also a very substantial documentation on Q&A, quick lines, tough Q&As that are also available for countries that are either rolling out the vaccine or preparing and want to be sure that they have all the answers to tricky or straightforward questions that might come up. Next slide, please. For the countries that already implemented the campaign and the rollout, we've seen the whole range of communication activities. And we also planned for a lot of risk situation and crisis situation and risk anticipation exercises took place ahead of time just to make sure that we're not running into any type of crisis with the new vaccine. So everyone is aware of what nOPV is and how best to address possible questions that might come up from the community. So that all was included in the pre-campaign engagement of the communities. And we also worked a lot with religious leaders and with other government officials at a state level. And of course, a lot of work went into frontline workers. Next slide, please. A little bit about the challenges. COVID-19 not only have forced us to pause the campaigns, but when we started implementing the campaigns, we have faced challenges both with implementation, but also with communication. It is a very busy environment information-wise out there in terms of public health emergencies, and COVID-19 is prevailing. There is a lot of misinformation out there, which we're seeing and addressing. It's mostly about COVID-19 and COVID vaccines, but because it's a top of mind topic, a lot of the communities are confusing the COVID vaccine and polio vaccine, and we saw we had quite a challenge explaining the difference without jeopardizing COVID vaccine, of course, but explaining the difference between polio and COVID vaccine. So misinformation work and rumor management work is quite important and is ongoing in all the countries, and we're encouraging countries to start as early as possible and not wait until the actual campaign rollout. We're also continuously following up with the countries on the need to adhere to the EUL commitments. There are 3 commitments from communication perspective that countries are encouraged to adhere to. Next slide, please. On the positive side of things, as I said, there were no major rumors linked directly to nOPV. Those that we've seen were addressed and tackled pretty easily, both online and offline. We had in Nigeria and Liberia success in engaging the main infrastructures that were out there already established for the polio outbreaks, and the health workers and DCMs. Frontline workers were engaged and trained, and that was successful. We have also worked with the traditional and religious leaders. High-level advocacy was absolutely necessary and required, and our plans as a G1 were well received. And we have widened advocacy beyond the Ministry of Health, engaging all relevant stakeholders, and we're continuing doing so with other countries. We are learning a lot from the data that we're receiving after the round 1 in some countries and both rounds in Nigeria. We are putting together lessons learned to share with other countries on how we can improve on communication and how we can avoid managing misinformation, but rather not have the misinformation out there. But as I said, we are quite lucky, and thankfully up until now there was no major crisis, and we had 3 countries successfully implementing the campaigns. Thank you, Simona. I think that's where I stop.
Great. Thank you so much, Mariana. And thank you as well for this photo of a child receiving nOPV2. So just so that you all know it is in fact real, and that is actually what the vial looks like. So it is a 50-dose vial, but you'll see that it looks very similar to the other OPVs. It has the VVM and it's delivered orally with the same type of dropper. So it's great to see that it is being accepted and there haven't been too many problems from the communications side. Our next presenter is going to tell us about an area where we also hope there haven't been many problems, which is around safety. Zunera is from the CDC safety team and has been the lead on the nOPV2 safety work, which is a much bigger piece of work than she ever knew it would be when she said she would help us, but we are forever grateful for her support and guidance. And Zunera is going to give us an update and answer one of the questions I saw in the chat as well about the AESIs for nOPV2. So Zunera, over to you.
Thank you so much, Simona. So hello, everybody. Good morning, good afternoon, good evening. Next slide, please. So today I'm going to cover an overview of the nOPV2 safety surveillance monitoring system and describe the safety data available for review. Next slide. And I'm going to start with some definitions. So first of all, VREs are vaccine-related events. These are events related to vaccines that can negatively affect a vaccination program. These include adverse events following immunization and adverse events of special interest. VREs also include new studies or experimental data related to vaccines, importantly, a press report or local rumor about vaccines, or a temporary suspension, recall, or replacement of a vaccine. Adverse events following immunization or any untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the usage of vaccine. The adverse event may be any unfavorable or unintended sign, abnormal lab finding, symptom, or disease. Adverse events of special interest are pre-identified and predefined medically significant events that have the potential to be causally associated with a vaccine product that need to be carefully monitored. Next slide. So this slide shows the components of the safety surveillance system. We have adverse event following immunization surveillance. This is a passive system already in place in countries, and this is to detect reported adverse events, including serious and unanticipated adverse events. There's also the AESI surveillance, which is an active system. It's time limited. This is to detect rare complex adverse events that may be anticipated based on what's currently known about polio and polio vaccine. There is also vaccine-related event response. And also what falls under safety is AFP and environmental surveillance. But for the most part, those won't be discussed. They're covered primarily in the surveillance pillar. Next slide, please. So this slide shows the safety monitoring activities in a little bit more detail. On the left, we have the AEFI surveillance activities, which include detection, notification, reporting, investigation, analysis, causality assessment, feedback, and corrective action. In the far right, we have the activities that have to do with the AESI surveillance, and these include detection, reporting, case ascertainment, verification, chart abstraction, and if the adverse event of special interest follows immunization, then there will be investigation and causality assessment. And there will be ongoing data analysis throughout the surveillance cycle. And in the middle, we have vaccine-related event response. And the activities here include activities to prepare, detect, and respond to a vaccine-related event. Next slide. So this slide shows the status of the safety surveillance activities in Nigeria and Liberia. For Nigeria, the AEFI surveillance has taken place, as has the AESI surveillance. There also has been the Causality Assessment Committee review of the serious AEFI and the AESI cases, which have followed nOPV2 use. There also has been the retrospective AESI case search and the environmental surveillance. And in Liberia, we understand that the activities that have taken place include the passive AEFI surveillance. And we recognize that it's a lot of work to prepare for these activities and to implement these activities. And we congratulate both countries on their hard work in implementing the safety surveillance system. Next slide, please. And this slide shows in a little bit more detail the specific safety data that we are looking at, which is important in the context of the data submitted to the Global Advisory Committee for Vaccine Safety, the nOPV2 Safety Subcommittee. So the data that we are reviewing for that include campaign and surveillance data quality, line listed and aggregated AESI and AEFI data, as well as case summaries and causality assessment outcomes. Next slide, please. And the analysis of the safety data focuses on a descriptive summary of AEFI and AESI data by country. We're looking at demographic characteristics, number of events, onset intervals, incidence rates, the diagnostic certainty for the AESI, and looking at these by vaccination status. Next slide, please. So this shows the safety data that's available for review. And as mentioned by several of the presenters, there's a meeting of this Global Advisory Committee on Vaccine Safety next Wednesday, the 26th, where we will present some of this data in detail. So from Nigeria, what we have available is aggregated and line listed AESI and AEFI data, as well as case summaries for the AESIs and the serious AEFIs. We also have retrospective AESI search data and environmental surveillance data available. And from Liberia, we have aggregated AEFI data available. Next slide, please. And I just want to say that I know that there's a lot of interest in this data. We received this data very recently, and right now we are doing the preliminary analysis of this data. But I want to add that based on the limited data that's available thus far, which we have been able to review in a preliminary fashion, there have been no serious AEFIs or AESIs identified that have been causally associated with the nOPV2 vaccine. So this is encouraging, but more analysis needs to be done. Next slide, please. So in summary, the AEFI and AESI surveillance are key components of nOPV2 safety monitoring. Surveillance activities include detection, reporting, case ascertainment, chart abstraction, and if vaccination is documented, investigation and causality assessment. The data analysis focuses on a descriptive summary of AEFI and AESI data, and preliminary analyses are currently being conducted. And that's it for me. Thank you very much.
Great. Thank you so much, Sunera, for that really clear and comprehensive overview. I think this is an area that a lot of us in polio aren't that familiar with, so it's great to have it explained so clearly and to be so detailed about all of the different data that you're looking for. And it's really wonderful to see that all of those green tick marks in the Nigeria column, and a big thank you to the regional team for facilitating that. As Dr. Richelieu highlighted, we did have 7.9 million children in that first round in Nigeria who have each by this point now received two doses. So that's, 18 million doses, so 16 million doses approximately that have been administered there, plus around another 2 million from Liberia. So hopefully that will be a good set of preliminary data for the committee to review. And indeed, we will continue to work to get the additional data. I would now like to hand it over to Ananda, my co-chair from the nOPV2 working group, who's going to give you an update on the additional pieces of data that we are continuing to gather, in addition to the safety data that will help us exit that initial use phase, as well as the genetic stability data that comes out of the environmental surveillance, and that analysis is also ongoing, so there's no update on that at this point. There are several other studies that are ongoing, either formal clinical trials or research pieces that will help inform our use of nOPV2 and guide our policy decisions. So Ananda, over to you for a bit of the history of how we got to where we are and an outline of where we're going.
Thank you so much, Simona. Greetings to everyone. So as Simona pointed out, I'll focus on the clinical studies, both the studies that have been done and also studies that we are supporting now or are upcoming. And we'll go through the highlights of the clinical data generated and also the kind of data we expect to be generated in the coming few months and beyond. So let's go to the next slide, please, Emily. This is a one-slide summary of the key clinical studies that have been done to generate data on nOPV2 to support its EUL approval, essentially. So what you see on the right-hand side of this slide are the clinical trials that evaluated nOPV2. Essentially, we had 3 clinical trials, 2 in Belgium in adults, and 1 in Panama in children and in infants. Essentially fairly large studies, particularly when it comes to phase 2 studies that were done for nOPV2. Now, these studies were compared in terms of the data generated with earlier studies done with Sabin monovalent OPV2. And these studies you see on the left-hand side also done in the same geographies. So overall, this set of approximately 5 clinical trials constituted the EUL enabling data that were generated. I would like to take this moment to thank the WHO Euro and PAHO colleagues and also the country colleagues who supported these clinical trials to be implemented much before the use and the EUL review of the vaccine. Now, primary endpoint data from all these studies have been generated and they have in fact been published in the Lancet. In the next slide depicts the studies that we have already published. So Emily, next slide, please. So these three publications have all the primary endpoints data from the studies that I just mentioned. These are available for for public access. And as I said, these data essentially form the core basis of the EUL review when it comes to the clinical data around nOPV2. I'll go through three essential highlights of nOPV2 data, focusing on the target population, the infants and the young children. So I've prioritized the Panama study data for us to all understand how nOPV2 behaves in the target population. So the next slide, please. This is published data. This is data on seroconversion with nOPV2 being compared with the monovalent OPV2 Sabin. So obviously we're trying to answer the question of whether or not nOPV2 generates adequate amount of neutralizing antibodies post the dosages in target populations. And how does it compare with nOPV2? As you know, seroconversion rates are typically taken as the indicator, of protection of individuals against paralysis. It's taken as the correlate of protection. And in the graph, you see how nOPV2 behaved compared to Sabin monovalent OPV2. So Sabin monovalent OPV2 is depicted by the purple color here, whereas nOPV2 in two doses, low doses in green and then high doses in orange, we have the nOPV2 data. So basically, with one dose of nOPV2, when we measured the antibodies 28 days after the first dose, there was favorable seroconversion rates that we noted, essentially around 86% with the novel OPV2, irrespective of the doses, high or low, compared to close to 90% with Sabin monovalent OPV2. There was no statistically significant difference across these different vaccines or doses. And similarly, when we went to second dose and post-second dose evaluation, essentially all three types of doses or the two types of vaccines, looked essentially equivalent. So post the second dose, which as you know is the typical target dose for SIAs, we typically conduct at least two SIAs for outbreak response. The seroconversion rates were more than 95%. So this was essentially a very reassuring piece of data that came up from that Panama study. And this was consistent with what we saw with the Belgium studies in adults. Next slide, please. So after we assessed the seroconversion rates or the individual protection, now was the time to evaluate how does it behave in the gut. So does it replicate much like the Sabin monovalent OPV2? And if it does, what's the pattern of viral shedding? So in this graph, you essentially see the percentage or essentially proportion of subjects who are shedding the vaccine virus, either nOPV2 depicted in the orange color here, or Sabin monovalent OPV2 depicted in purple or blue. And what you can see is essentially an evaluation of overall PCR positivity of shedding, and also in a subset, we also are reporting culture positive shedding. So essentially, the live replicating virus being shed is also being assessed over here. And the overall picture again is very reassuring. So Emily, if you could click on this slide once. So if we focus on a post-dose 1 evaluation, you can see there is essentially no difference from a statistical standpoint between Sabin OPV2 and the novel OPV2. Although in the tail end of shedding, day 21 or day 28, we see the difference being a bit more prominent, where there is an apparent earlier cessation of shedding with the novel OPV2. But again, I would reiterate, overall, there is not much of a statistically significant difference in terms of post-dose 1 shedding between the two vaccines. Next click, please. If we focus on the second dose, the pattern overall remains the same, although what is really important to note with the second dose or the post-dose 1 evaluation compared to the post-dose 2 evaluation is the continued reduction in terms of shedding compared to the post-dose 1 shedding, which really indicates in an indirect way that the first dose did induce primary intestinal immunogenicity, which leads to the lower shedding with the second dose of the vaccine. This was true across Sabin monovalent OPV2 and novel OPV2. So again, from an intestinal immunogenicity perspective, these data are very reassuring, confirming the fact that nOPV2 essentially replicates in an equivalent, comparable way with the Sabin monovalent OPV2. If there is any difference, probably it is in the tail end of shedding, as I said, with slightly earlier cessation of shedding with nOPV2. Again, this was from the infant population. This was not much different from what we saw in the other age groups where we evaluated nOPV2. Next slide, please. The final piece of data is around genetic stability, and here I focused on the neurovirulence data. Please note that obviously throughout the trial populations, we did not come across any events of paralysis. These data are from essentially experimental situations where we have pressure tested the nOPV2 vaccine compared with the Sabin monovalent OPV2 vaccine. What we have done is we have identified one sample across the different shedding samples that we had from these subjects. Then that one sample has been amplified, and then the amplified virus was inoculated intraspinally in transgenic mice population to look for paralysis. And what you see is a striking difference between the Sabin monovalent OPV2, where we did see the Sabin monovalent OPV2 in those highly selected samples to revert readily to neurovirulence at a very high rate, compared to the novel OPV2, where the neurovirulence was either non-existent or happened at a very, very low rate, compared again to the Sabin monovalent OPV2, which was again the central purpose of the development of this vaccine, to ensure they maintain the immunogenicity and replication properties of the Sabin OPV2, but does not have the same risk of reversion into neurovirulence compared to the Sabin OPV2. So again, overall, very reassuring. Moving quickly to the upcoming studies or the studies that are ongoing, this is a one-slide summary of many studies that are being supported, from clinical studies to observational studies to field research like seroprevalence studies that are being supported as nOPV2 is being used in the field. I'll focus on two for today. If you click on this slide, please. The naive infant immunogenicity study in Bangladesh and the phase 3 study in the Gambia. So the next slide, please. So when it comes to this study, this is essentially a study where a birth dose of nOPV2 is being given, followed by a second dose at 28 days of life, and then safety and immunogenicity of the vaccine is being evaluated. And the good news is that the study is near complete. Enrolled 316 subjects out of 330, and we are expecting to see the first readout of serology results from this study by Q3, Q4 of this year. Next slide, please. This is the phase 3 study for nOPV2, a requirement for pre-qualification and licensure of the vaccine. This is taking place in the Gambia. And again, despite the pandemic, the study is ongoing and have enrolled around 600 subjects out of the target approximate 3,000. And so far, it is going well. From both these studies, the Bangladesh study and the Gambia study, the safety evaluation is ongoing as the studies are progressing, with a very active involvement of DSMBs, the data and safety monitoring boards, and so far it looks promising, which has enabled the further progression of these studies. We're obviously closely monitoring the situation in Senegal with the CVDPV outbreak, and whether or not this affects the conduct of the study in the Gambia remains to be seen. Next slide, please. So overall, this was a quick run through the clinical world of nOPV2 with the studies that have been completed, studies that are upcoming. As you can tell, overall, there is continued progress in data generation as nOPV2 is being used in the field. Overall, the pattern of new data that I shared with you is consistent with the earlier data that have been published. The timelines, although have been impacted with the clinical studies, but they remain more or less on track for the eventual data generation, and that is despite the pandemic. Again, kudos to all the study partners and the country-level collaborators who have worked so hard in very difficult circumstances to implement these studies. The focus now is to essentially ensure that the regulatory submissions from these ongoing studies and the preliminary data that are being generated, the coordination is done well across the regulatory submission plan as the field implementation of the campaigns happen and data comes from there, and also the studies that are ongoing that I just mentioned. So it will be the focus for the next several months that we ensure a streamlined mechanism of not only data generation, but data dissemination across the partnership and with WHO PQ and the EUL team, so that the continued use of the vaccine can be supported. I thank all the team who have been engaged in this work, and I hand it over to Simona.
Great, thank you so much, Ananda. And I think you ended on a really great note, which on the regulatory coordination. I think that is something that was really so important for us in obtaining the EUL, the really strong support from the WHO pre-qualification team and the Indonesian regulator. And I think we're lucky that we squeaked in before their workloads increased so dramatically with COVID, but they continue to support us on the side, and having their guidance as well as their independent and thorough assessments, I think has given us a lot of confidence in this vaccine, along with, of course, the clinical findings. We're going to move on to questions in a minute. And so thanks to those of you who have put them in the Q&A box. And if you have a question that you've been thinking about asking but haven't asked it yet, now is a great time to put it in the Q&A box. But before we get there, I'm going to pass over to Joe Swan from WHO, who is Mariana's partner in crime on the nOPV2 communications project team, to talk you through some of the resources that are available for nOPV2 in case you think of a question later on, or you're perhaps in a country or at a regional level and are working towards preparing for nOPV2 use. You know where you can get some information on everything from policies to scientific research to tools and videos and FAQs. So Joe, over to you.
Thanks a lot, Simona. Hello, everybody. So as Simona mentioned, just ahead of the Q&A session, I'll give a quick refresher on GPEI's nOPV2 webpage. So a lot of you are probably already familiar with this webpage, particularly those in countries that are implementing. But in case you're not, this is our one-stop shop for all things nOPV2. The URL, as you can see on the slide, is polioeradication.org/nOPV2. So basically the GPEI website with a /nOPV2. This web page is updated fairly frequently as new information becomes available. You'll see on the slide that I've pasted a screenshot of the page, and you'll notice a series of drop downs in bold there. Categories for the materials are fairly straightforward, self-explanatory. The general content, a lot of the general content is found under the overview, documents, fact sheets, and FAQ. You'll see that as the very first line of text under key resources. Here you'll find a lot of handy quick reference guides, like the FAQ document, a CVDPV2/nOPV2 fact sheet. You'll find an animation on nOPV2 as well as an overview PowerPoint presentation, among other things. The more in-depth technical content will sit under the other drop-downs. For example, we have scientific research papers, regulatory documents, technical guidance, and the readiness checklist, which countries use to get ready for nOPV2 implementation, as well as guidance for cold chain, surveillance, vaccine management, safety. It's all under those subsequent drop-downs. Under that, you'll see that we have a media center, and this basically includes a list of links for GPEI nOPV2 articles. Also in there is a really handy guide for our comms professionals out there, a guide for responsible reporting on CVDPVs and also nOPV2. So this is a tricky topic for journalists to get right. This is a great resource to share with our journalists if they're planning stories on outbreaks or nOPV2, or even if you would like to know how GPEI communicates on these topics. That's a good reference guide. Content on this webpage. Now I'm not navigating through the drop downs here, but if you explore the page, you'll see the various content is available in English and French. A lot of the documents are available in French. We also have some of them available in Arabic, Portuguese, and Russian. If you haven't yet seen this webpage, we encourage you to take a look, surf around. If you have any questions on content, feel free to get in touch with me. That's fine. This webinar is being recorded, and it will actually be going up on this web page as well. So look out for that. If you have colleagues who wanted to attend but couldn't, we'll have a recording of this webinar placed under the overview documents in the next week or so. So that's it. Oh, sorry. Before I pass over, there's one more thing. You'll see at the very bottom we have additional resources and updates. So for more information on the nOPV2 working group or on the GACBS subcommittee, there's some TORs there that explain the various work streams of these groups. But yes, I'll stop there and pass back to Simona. Thank you.
Great. Thank you all so much. Thank you, Joe, for the update. There is a wealth of information on the webpage, and most of it is available in English, French, Arabic, Portuguese, and many documents in Russian as well. So please do have a look through there if you're looking for specific information. And as Joe already mentioned to someone who had posed the question, this webinar will indeed be posted on that webpage. So there's further incentive to check it out. As usual, we've run a little bit over with our presentations, but we do have time for some questions. Thank you to our panelists who've answered several of these in the Q&A box already, but we wanted to get to a few of them now during the group discussion to make sure that everyone heard the answers to some of these questions. And for those that you haven't had a chance to answer yet, that you have a chance to provide an answer now. So Ananda, Jude asked a question which you've answered in the chat, and I'm hoping you could just speak to a little bit now, because I know it's a question that we've heard several times before, which is that the population immunity in the countries where the studies were done is relatively higher compared to the population immunity that we're seeing in several of the countries in the African region that are currently facing CVDPV2 problems. And so his question is, what is the likelihood of having similar problems in countries with low population immunity?
Thanks, Jude. And it's a valid and important question. The point is we'll really know the specific answer, once we have additional data from the field use and the studies like Bangladesh and the Gambia. But we also have to note we have sufficient indication already with the studies that have been done. So if you look at the Panama study, the subjects in that study were naive to type 2 live vaccine. So irrespective of the background population immunity, during that study, the specific subjects who were evaluated for nOPV2 seroconversion, nOPV2 intestinal immunogenicity, and then nOPV2 genetic stability, all these subjects never received a type 2 OPV before. So their guts essentially, were naive to live type 2. And we did have a good opportunity to evaluate, these specific endpoints. The endpoints around population immunity or evolution of CVDPVs are beyond clinical studies. So that's why I said the continued field use, the monitoring of the data that come from field use will be important to essentially add on to the understanding that we already have. But I wanted to make sure, we all understand the context, under which the studies were done, which did give us an opportunity to peek into what might happen once we use the vaccine in OPV2 naive populations. Over.
Thanks, Ananda. While we have you here, we have another question for you from Loveday, who's asking about the shedding of nOPV2. And she or he is noting that the shedding of nOPV2 is reduced with time and with the second dose, but there is shedding with only one dose. And so is wondering what impact you feel that will have on the children and on the efficacy, and whether or not, when the campaign quality is perhaps not so strong, would there be a need for a third campaign in areas with poor coverage?
These are great questions. So first of all, the intestinal immunogenicity pattern that we saw with nOPV2 is close to what we wanted to see. We do want to see the vaccine replicating, because that's one of the quote good things of Sabin OPV2, where through the replication you have local gut immunity. And what you also want to see is that post that replication, there is intestinal immunity, which is indirectly measured with the second dose performance. So once you give the second dose, given that the first dose already induced intestinal immunity, there is lower shedding post the second dose. So that is exactly consistent with what we typically want to see. Now, to your other question, whether we will eventually need a third dose or not, I think that's an important one, and we'll really have to see the effectiveness of nOPV2 in the field to determine that. For now, as you noted, when it comes to seroconversion with nOPV2 and also intestinal immunogenicity, there is not much of a difference between Sabin and nOPV2. So one would expect we will use nOPV2 in the same manner like Sabin OPV2. And so in some areas when campaign qualities are typically compromised, we might have to use another dose, much like what we have done with Sabin OPV2. But that's not a given, and that's something we'll have to continuously monitor and evaluate, because it's not only the vaccine characteristics, it's the vaccination characteristics, that will determine whether or not a third dose will be needed. As of now, it seems like it's going to behave much like the current vaccine when it comes to immunogenicity.
Thank you, Ananda, for that very clear explanation. While we're on this topic of shedding, Dr. Sume is wondering if you could explain a little bit about the impact of the lower shedding on herd immunity. And as you said, we do want to see some shedding, so are we concerned that we're seeing less of it?
That's again a difficult one to answer, and the simple answer is that the difference that we saw in here is marginal and probably not going to have a clinical or an epidemiologic impact with this marginal difference. What we want to see is the replication happening, and that's typically seen in the first 2 weeks or so post the vaccination. That's when the peak of shedding is reached. And at that peak, we did not see much of a difference between the nOPV2 and Sabin OPV2. Although we don't understand the population level impact of such shedding patterns well, it is broadly understood that it is that peak shedding timing and extent that probably impacts the transmissibility and herd immunity more than the tail end of shedding, where anyways much less proportions are shedding, be it Sabin OPV2 or novel OPV2. So I think early days to really comment in a confirmatory way whether this is going to have any herd immunity impact or not. Likely not is what I would say from what we are seeing from the clinical studies.
Great, thanks, Ananda. Grace, the next question is to you. Given that we've seen so many check marks in the Nigeria column for data collection for safety, but we're missing several columns from check marks in the Liberia column, could you let us know how much data the Global Advisory Committee on Vaccine Safety subgroup wants to see in order to move out of the initial use phase?
Hi, yeah, so that's a really great question and something I can't provide a definitive answer to, as it will be up to really the discussions of the GACS committee, and the first meeting will be next week for them to review the data so far. But we are hopeful that as the Nigeria campaign was so large with kind of 8 million doses per round, that the data from Nigeria, we hope, would be sufficient to demonstrate safety. And then as Liberia collect more data and that process goes along, maybe the data from Liberia could support that. But the Nigeria database would hopefully be the bulk of that data that's needed to recommend the transition out. It would just depend on whether the subcommittee feel that they need data from more than one geographical country or setting. And I think Zunera has her hand up, so she may want to add more to that. She's really the safety data expert here.
And
that would be great. Zunera, over to you.
Sorry, thanks, Grace. You answered that really well. I also just want to add quickly that it's not just it's the data, the amount of data, the number of doses, that's critically important, but also critically important is the quality of the surveillance. So the campaign and the surveillance quality indicators really will give context to the data that we have. So for example, if we're only seeing data from a few states on AEFIs and AESIs, that points to maybe an issue with the quality of surveillance being done. So I think that the GAC Safety Subcommittee will be really interested in the surveillance quality indicators as well. Over.
Great, thank you very much, Sunera and Grace. It is one of the hot questions, but indeed a hard one to answer definitively. I think you both highlighted, wow, how many different variables there are. We are going to wrap up this webinar shortly, but before we do, we wanted to just show you a little animation on nOPV2. This is a short overview that can be put together and shown to country partners who might not understand what the vaccine is, or shown to stakeholders as part of sensitization around nOPV2. So this is available as well in at least English and French. I'm not sure about the other languages, but wanted to show it to you today as we end. It's very short so that you know this resource that is available to you on the website, as Joe highlighted. So Emily, when you are ready, go ahead.
With the oral polio vaccine, or OPV, the world has made incredible progress towards eradicating polio. Increasing vaccination coverage has helped reduce cases by more than 99% since 1988. However, challenges remain. In rare instances, when not enough children are vaccinated with OPV, the weakened virus in the vaccine can pass among under-immunized populations and over time, change to a form that can cause paralysis. This is known as circulating vaccine-derived polio, or CVDPV. In recent years, we've seen an increase in CVDPV outbreaks. Novel oral polio vaccine type 2, or nOPV2, is an improved version of the current vaccine used to respond to CVDPV2 outbreaks. To address the ongoing global public health emergency of polio and stop these outbreaks more effectively, the Global Polio Eradication Initiative, or GPEI, is working with countries to deploy this innovative tool. Research has shown nOPV2 to be similarly safe and effective in protecting against polio as the current vaccine, but significantly less likely to change to a form that can cause paralysis. Based on this promising data, and given the increasing number of CVDPV outbreaks, the World Health Organization has recommended nOPV2 for outbreak response under its Emergency Use Listing (EUL) procedure. Under EUL, nOPV2 will be closely monitored. The GPEI anticipates that the vaccine could play a major role in the fight against polio when used alongside existing vaccines and outbreak response tools. nOPV2 could be a key tool, but in order for it to stop outbreaks and for the world to achieve and maintain a polio-free future, all children must be reached with polio vaccines. Working together with communities and partners, we can rid the world of all types of polio.
So on that note, we will thank you all for spending 90 minutes of your busy schedules with us today. The recording of this webinar will be available on the nOPV2 page of the globalpolioeradication.com website. So please do go to polioeradication.org/nOPV2 for all of the nOPV2 information, as well as a copy of this webinar. We wish you all a good rest of your day, a good evening for those of you in Asia, and a good start to your day for those of you in Seattle, and afternoon to those of you in the middle. Thank you very much. Bye-bye.